Thank you very much for that nice introduction. I should say that I was born in Cuba because they didn't ask me. It was my mother's decision. But if it would have been my decision, I would have been born in Tampa. And this is the guy that I was telling you, the resident that I was married. This is my brother from Pasagrill. They are from Tampa, but they don't know Pasagrill. And I had to do it right here, Bob. Bob does not want people to discover Pasagrill. Even people from Tampa, they don't want to discover Pasagrill. But it's not fair, Bob. Pasagrill is the most beautiful place in the whole planet. And you should go and know Pasagrill. At least I'll be there tomorrow, so I will enjoy it one more time. Frank is an old brother. And I am very sorry that he's not here today because guts I have. If I were not to have guts, I would not have moved as I have moved in my career. To come to Tampa and to talk about HIV when Bob is #1 in the world, I tell you, I had guts. So I wanted to talk to him today about my update in relation to HIV and mood disorders, but unfortunately he was not able to be here because he did in someplace else. But I want you, when you see him later on today or tomorrow, and I want you to tell him, listen, you know, you are good, but I think Pedro is better. That will force him to invite me again, and something which I will really like that again and again. I think this is like my 3rd or 4th times giving around rounds here at University of South Florida. I have always enjoyed it, and I am very, very happy to have the opportunity to update you in this particular topic. As you all know, HIV is very relevant, it's growing all over the world. Southeast Asia is really the region of the world that will be more impacted in the next few decades, but in the United States, it's a major problem as well. The American Psychiatric Association is very much interested in helping out and assisting psychiatrists, all the practitioners in this particular topic, and in many ways, what I'm going to be presenting to you come from the efforts of the AP8 Committee on HIV-Related Disorders. And as you also know, Frank and I, and I'm very happy and proud of that, Frank and I have a test book on HIV/AIDS. Psychiatric aspects of HIV/AIDS. And I don't know if you are aware of that book, but now you are aware now because I mentioned it to you. And I was the one that, in that particular book, besides editing it together with Frank, I was the one that dealt with the chapter on mood disorders. So I hope that it will be of interest to you today. I also will leave it here with the staff that was here helping me out. So if any of you want to have access, you know, to the material, you could ask her, and she will be most happy to give it to all of you. And she will also give a copy for you. From the point of view of making an overview, mood disorders are the most frequent psychiatric complications associated with HIV disease. Anxiety is very common, suicide is very common, but mood disorder is the most common psychiatric disorder for that particular patient population. It could be secondary to the treatment that those patients receive, very difficult and very complex type of treatment, but can also be, you know, part of the illness itself as well as part of the treatment. There are a lot of very effective, and this is what is very good, that as years go by, we develop more and more effective methods of handling that particular problem, and therefore, when we are now dealing with a patient population, we are able now to exercise more options than we used to about 10 years ago or so. And the most important factor that we also have to keep in mind when we're dealing with this patient population is the possibility that at any given time of the illness, that particular patient could commit suicide for millions of reasons. Despondency, depression, they are at the end of the illness, and they feel very guilty about it, or having secured it, or having given it to somebody else, and all that leads sometimes to suicide. So when we're dealing with that patient population, we have to have always in the back of our mind the possibility of suicide, and we have to openly and honestly ask the patient about it. 95% of the people who commit suicide in the United States have told they are physicians that they are about to do it. We are very bad. Physicians tend to be very bad in listening to that. If we were to pay a little bit more attention, we might be able to prevent a lot of suicide that should not have happened. But indeed, they tell us, not necessarily, I'm not talking about psychiatrists, I'm talking about primary care physicians, all the type of super specialty areas as well, but they do tell the physician that they are considering suicide, they are about to die, and we just look at the other side. When we're talking about risk for depression, we have to look at the possibility of prior mood disorder. If that particular patient, before he got infected by HIV, had been suffering from depression, or had a relative of him or her that suffered from depression, the possibility that that person that is now infected, developing a mood disorder illness, is very high. We also have to look at the personal history of that individual. Alcoholism, substance abuse, all those two diseases are very much related to depression. Also, suicidal intent. Have that particular patient ever felt, like committed suicide or tried before? And also history of anxiety disorder. All of that we need to explore in every single patient that we see that is getting depressed and also suffering from HIV. We also have to look at the family, not only patient. Had the family been on substance abuse? Had the family been on alcoholism? Had the family, had anxiety problems in the past? Had the family been depressed in the past? The possibility between the family having one of the illnesses and the son or the nephew or the cousin, of any of those members, suffering that type of disease is very high. And if they have HIV, then it's even higher as well. If there are current alcohol use or drug abuse, then the situation becomes very more hectic and more difficult, and we have to be very cognitive of that, because sometimes alcoholism is trying to cover up the depression, and sometimes substance abuse is also trying to more or less self-treatment, themselves. And we have to look at the support. If the patient has support, the patient has a partner, the patient has a family, the family is willing to accept that the patient is HIV positive, the family is willing to accept that the patient is a lesbian or a gay. Very important. If there is no support around, then the possibility of committing suicide due to isolation and lack of attention and lack of support goes up. And sometimes you are the only one that the patient will have for that support. So besides being the physician, the psychiatrist that will be prescribing, listening, and treating, you also have to provide all kinds of support. At times, be like his brother, like his friend, be like a family member, and try to fill the gap until such a time that the patient has a better support system. Non-disclosure factors also lead to depression. The patient gets so depressed, so concerned about not divulging that they have HIV positivity, that sometimes the stress that they are experiencing is so high that ends by the person developing the depression. Those are patients that are also exposed to a lot of multiple losses. A partner of his or her, died to the disease. Another good friend, died to the disease. They see 2 or 3 people, that are dying in their surrounding, and therefore they themselves become very sensitive about that. And one of the questions that they always ask themselves is, well, when will it be me? I lost my partner, last week. I lost another friend and another and another. What is going to happen with my own HIV positivity? I probably, will die soon too. The degree of the advance of the illnesses, sometimes the illness has already been very advanced. And usually the internists or the immunologists or the psychiatrists treating those particular patients, they keep them abreast, because there is a lot of disposition that have to be made from the legal point of view, family point of view, that also have to be taken into consideration. And therefore, sometimes many of these patients know that their illness is beginning to be very advanced, and the possibility to die is getting close. And sometimes they are also experiencing the fact that they have been treated, and we have now plenty of treatment. About 2 decades ago, we have very limited options, when we were treating HIV, but now the options are there. But nevertheless, sometimes we have patients that do not respond to this one, to that other one, to the different type of medication. And when they have to experience, that failure to treatment, sometimes they get even more depressed. And then there, the possibility of suicide is also a possibility that has therefore to be taken into consideration. Some other times, and this is very interesting, some other times they succeed in getting better. They are definitely getting better with the treatment. Something that is happening today as a result of the research that we have been doing during the last 2 decades on that particular topic. Now, people that are infected, they live for decades. It's no longer a matter of 2 or 3 years. Some of them are living already for 20 years, and continue to live. But sometimes they are able to survive, but they have a lot of friends who didn't have the luck and they had died. And then sometimes when they survive, they feel very guilty because why me? Why my partner were not able to survive? Why did I have to lose him? Why do I have to lose this guy who was a very good friend of mine, and we were together, as friends, for the last 10, 15 years, and he died. And then even though they themselves might be succeeding with respect to the treatment, sometimes the depression is such as a result of that particular issue with respect to other people that had died in the surrounding that they decide to kill themselves as well. We have to be very much in tune with the type of manifestation of the symptomatology, and I think you know about this because being in this good training program and been residents most of you already, you probably know it, but I think very quickly we'll go over them as well. We have some set of manifestations that are affectively related, and we have some other set that are somatically related. Among the ones that are affectively related, we have depressed mood. A person feels down and feel fatigued and doesn't feel like going to the movie, doesn't feel like eating, doesn't feel like going on visit with the friends, and it's really, the mood is down. Loss of interest. The patient, is a pianist and he's no longer going to concert. That person is a physician and he's no longer going to go rounds and things of that nature. That person, because the type of personality that he or she has, they have a lot of guilt. And they feel also worthless very easily. Oh, I value nothing, I know that I have been alive now for 10 years with illness, but actually had died. I am not working, I don't have the strength to work, I have to retire, I am suffering from this, I'm suffering from that, and then they feel worthless. And they tend to have a lot of suicidal ideation. Those people that have affective component, they also tend to be very frequently, high in terms of suicidal ideation. But then on the other side, you have some somatic manifestation. From an affective point of view, you're not doing too bad, but then you begin to lose weight. You're not eating that well, and then the appetite is gone, and then you have difficulties with your sleep. Sometimes it's a stress. As you well know, stress is you woke up many times in the middle of the night, or you have anxiety, you have difficulties in falling asleep, or you have a more established depression. You woke up very early and you won't be able to go back to sleep. So the respective of the type of sleep disorders that you have, sometimes they are associated with somatic manifestation. Sometimes you get agitated. You get extremely agitated, all of a sudden you become hyperactive, you spend money and you spend more money than you have, and you buy the new car and this and the other without able to sustain it, but you get retarded. You get very slow, you're not thinking along the same line that you were in the last several months, and so on and so forth. Or you feel very much fatigued, or your concentration, which could be as a result of stress and as a result of anxiety, but also as a result of depression, your concentration began to get blurred a little bit. So you have to differentiate those particular patients that tend to be more effective with those particular patients who are more somatic. In occasion, you got patients, of course, that have depression, and they have both. They have the affective component, and the somatic component as well. Sometimes the treatment, depending on which one of the two prevails, or if the two prevail, might be in one way or might be in another way. We have plenty of agents in order to treat the patient among the HIV population at the present time. We have, of course, antidepressants. And among the antidepressants, we have, the SSRIs, so we tend to use it quite heavily and quite often. But you have also some novel antidepressants that we're going to review that also have to be taken into consideration. And we tend not to use tricycles any longer. We try to look at tricycles. The tricycles were negative from every point of view. Well, not with this patient population. This patient population, tricycling has some unique characteristics that tend to be very positive for patients that have HIV positivity. And I will review those a little while. And although we tend to be shy, by using psychostimulants, and we tend not to use it all unless there is no more recourse. In that patient population, sometimes you feel about this, you feel about that, you feel about the other, and then you are against the wall, and you should be ready to use psychostimulants if needs be. With other type of population, you should not perhaps do it, but this patient population, if they had failed already to several treatments of SSRIs and this and the other, sometimes you have to record to unless you prefer to let them die or commit suicide, which is not acceptable, or at least from my point of view. And then you also have hormonal treatment that you will not use necessarily for the people that are depressed in your own clinic, but the people that have HIV and become depressed, in many occasions, they could be treated with hormonal treatment, or we will touch on that as well. Let's look at the antidepressant or the SSRIs. All of the SSRIs, all of them, I end up pushing for the Pfizer against Lilly or Lilly against Seneca. This is your own decision, okay? I didn't come here to push for one or the other. But in general, all the SSRIs are more or less equally effective. One thing that you have to take into consideration that you follow very closely the level of CD4 count in the body. That gives you a little bit of an idea as to how much the patient is doing from the point of view of aggravation of the illness itself, the HIV positivity. They have no impact. Many people think that by giving SSRIs, the CD4 will go down, and they go bananas when they see that the CD4 don't go down, or sometimes it goes up, and they think that the antidepressant is not working. This is bad from our part, okay? The CD4 has no impact whatsoever with respect to any antidepressant that you will give. Fluoxetine, usually 10 to 60 milligrams a day, is highly protein bound, and it have a very long half-life. Sometimes it's about 2 weeks, sometimes it's about 3 weeks, and inhibits the 2D6 metabolism in the body. Everything that you're going to use that plays a role with the metabolism, you must be very careful about it. Very careful about it, because it might impact negatively with the medication that this particular patient is taking for the HIV positivity. And then sometimes the two of them begin into a coordination, and then the patient gets into a lot of trouble. So we have to, you don't have to become a chemist, when you are using antidepressant for HIV individuals that are positive, but you have to look a little bit at metabolism. If you don't, then review it a little bit. You don't have to, again, to become a chemist, but review it a little bit so you will be more vested and more aware of what happens with respect to the metabolism. Paroxetine, 10 to 40 milligrams, highly protein bound again, induces its own metabolism. This particular drug has perhaps the only one of the SSRI that had that type of characteristic. Sometimes the drug itself get killed by the metabolism that the drug has in the body of the patient, and is the most potent inhibitor or the 2DC area of the body. So it's a medication that it creates so much complexity. It could lead to so much disaster from the metabolic point of view that I tend not to use it ever, unless I fail with any other antidepressant. I do not use paroxetine. If I fail with any other one, I have no other choice. But even if I fail, I would consider some other type of treatment before I go to paroxetine. So what I'm saying is that paroxetine is very bad for people who are depressed and have HIV positivity. Fluoxetine is a little bit better, but still is not the best one either. Sertraline, 25 to 200 milligrams, highly protein bound, shorter half-life of the SSRI, and have almost no impact on the metabolism. So here you have a wonderful SSRI that I tend sometimes to use it as the first line of treatment for a person that is HIV positive. Citalopram, 20 to 40 milligrams, less protein bound. Also sertraline has a shortest half-life. It doesn't have the 3 weeks, that the fluoxetine have or paroxetine have, and therefore, if something happens sour, that very quickly will get out of the body. Citalopram 20 to 40 milligrams, least protein bound and least P450 affinity of all of these SRI. Here you got another beauty, okay? No relationship whatsoever with the P450 metabolic action. So this is a medication that I feel comfortable using. So I got already 2. Citalopram and sertraline. I don't even know which one produces which one, the laboratory, but you got 2 here, okay? And I know that I will not use the other 2 the respective of who laboratory is the one that produced the first 2 ones. We also have some novel antidepressant that with respect to HIV positivity and depression we have to take into consideration. Among them, we have bupropion. Bupropion we used to, to use it a little bit before. Now we got so many SRIs that we just don't use it, very seldom use it. On the other hand, however, in persons who are depressed and are HIV positive, bupropion could play the role. When not throughout the whole illness, but as I said before, these days, patients who have HIV positivity, sometimes they are living for 2-3 decades already. This began in the early 80s, and some people are alive still, and they have been infected, since then. So for those type of people, particularly when they are getting old, or the illness of HIV for whatever reason began to be very aggressive, then bupropion is the way to go. It's very good because it's a little bit of a stimulant in a way, help out for the dementia and advance the case of HIV. Nefazodone, we tend not to use it here. Hepatic problems, 50 to 200 milligrams, highly protein bound, 3 and A4 significant interaction, and therefore, we should not use it. It's a novel antidepressant. It has some promise, but in the United States, although still I think it's in the formulary, people don't use it because of hepatic problems, and you don't want to gamble. You got so many SSRIs that why to gamble. But in some other countries, it just happens to be that you are in some other place that is approved, I will not use it. But Lafazine, here is another one, 7,550 milligrams, low protein binding, low affinity for the cytochrome P450. The Lafazine is, again, another good medication. Now, if your patient is depressed, but it also has some concomitant anxiety, here you got one that is a dual action and handle both of them. Mirtazapine, 7.5, 45 milligrams, low affinity, sedating, and gain weight. Okay. People don't like to prescribe mirtazapine because the patient can wait, and then they get angry at you and they blame you, and then you feel guilty. Although the patient is getting better from the depression, it gets very disappointed because it's getting away. But you have now a patient that has HIV positivity and is losing weight, and it looks like a cadaver. I go for mirtazapine first because the patient will gain weight by necessity in a majority of the cases, and then you are gaining the issue of treating the depression, but you are helping the patient to look better, to build a little bit his self-esteem, and then therefore you're killing several birds with the same bullet. Now, I was talking about tricyclics. We don't use it anymore, but what are some of the problems that we confront in patients that have HIV positivity? And of course, if they come depressed, then even more so. They develop diarrhea, a lot of diarrhea. They lose weight as hell. They look like they're going to die tomorrow. They're very anxious because it's to be anxious if you have HIV positivity. You don't know when you're going to die. You don't know when the medication will not work anymore. They become nauseated very often. Nauseated not because of the illness, but nauseated because they're taking so many medications in order to deal with the virus that they relate, to those medications with a lot of nausea complications. Anxious they are, as I said before. Sometimes they develop neuropathic pain, and the neuropathic pain has to be taken into consideration because it's painful and give them a lot of discomfort. And then also, you can, if a patient were to become, hopefully not, were to become suicidal and made a suicidal attempt, you can discover very quickly, how much tricyclic is in the body. Just one shot and you, in 20 minutes, you had the result. So tricyclics that I don't use almost ever when I have a patient that have HIV positivity and it's cachetic and is not eating that well and the medications are giving a lot of discomfort, I go for tricyclics, and tricycling is the way to go. Except if I know that the possibility of taking an overdose is right around the corner, but at the same time, however, I know that I could measure, through the blood. I could measure very quickly if the patient is beginning to take too much. Psychostimulants, which I hardly use for the patient population in general, I sometimes have to use it with patients that have HIV positivity and depression. You have both, methylphenidate and dextroamphetamine. Is used for some time on depression among the patient who happen to be medically ill. Sometimes internists use it more than we do. Sometimes internists ask us, for advice and permission if they should do it or not. With certain patients that are really medically ill and deeply down, fatigue and this and the other. It also helps with the cognitive functions. And sometimes, as you know, when the virus began to impact on the brain, they have some problems, along the line for cognitive functions. And you have to use it, with a lot of caution if that particular patient is not to have seizure or is epileptic or something like that. If that were to be the case, then you don't use it. If the patient had history of psychosis, or you think that it's getting, close to the border, you perhaps should not use a stimulant, because if you use a stimulant, then the patient might become psychotic, then you have the double illness that both of them are severe. And if the patient, feel fatigued because has lost a lot of weight and because he's depressed and all that, they can pep up, when they use a stimulant. So stimulants with patients who are depressed, or not only depressed, they have HIV positivity and negatively affected by the virus, you must consider psychostimulant as a potential way of treatment. When to go for psychostimulants? When to go for antidepressants? You're a little bit ambivalent about it. Should I try now psychostimulant? Should I try antidepressant first? Well, this is a little bit of a guidance. Early HIV positivity, try an antidepressant. Positivity that there will be potential cognitive dysfunction, probably not be there. So early on in the HIV disease, go for an antidepressant. The patient has been suffering from HIV positivity 10 years, 15 years. The patient is getting a little bit older. The patient is beginning to show some cognitive signs. Go for a stimulant first, rather than wasting time with antidepressant, particularly when sometimes you have to wait 3 or 4 weeks before the depressant, work. Previous history of depression, very well established. The possibility of recurrence. Go for antidepressants first. If there had been in the past depression that had been concomitant to impairment of functions, cognitive impairment of functions, or any type of manifestation of brain problem, go for psychostimulant first. Don't waste time, with antidepressant. No cognitive impairment, go for antidepressant. Significant cognitive impairment, particularly in advanced cases, then go for a psychostimulant. If there had been history of substance abuse, and it's very, very common, unfortunately, if that particular patient here have been used substances, long time ago, 10 years ago, 15 years ago, when they were young, and don't go for antidepressant. If not, then you could try, antidepressants, psychostimulant first, particularly if there is some impairment of functions, along the lines of the brain, either before or at the present time. Hormonal treatment is testosterone and the dihydrotestosterone, the DHEA, the one that we use more commonly. In those particular patients that are cachectic, those particular patients, that are, do not have any stimulation, sometimes you have to check, and sometimes the thyroid function are a little bit low and all that, then those are the classical patients. If the patient do not respond, to any type of antidepressant or any type of stimulant, those are the classical hormones. I'm not good too much of that, so I call Frank. And if Frank is not around, I call for an internist, help me out a little bit with the hormone. Now, psychotherapy and medication. Dr. Naher is here, and he needs to be pleased from the point of view that we also do psychotherapy, and sometimes even psychodynamic psychotherapy with the patient population. So I wanted to pay respect to him. I thought that he was going to be here. When do one works or the other works? In the personal therapy, you have 46% of positive response. This is effectively demonstrated. This, you don't have to necessarily, read 75,000 books. It had been, with evidence, it had been that interpersonal therapy works for depression, no question about it. In persons that have HIV positivity and depression, there is always a 46% response, that work. So that is not bad. Cognitive behavioral therapy, it works, but not as well. Okay? So when you have a patient that is depressed, and then on top of that, if the person has HIV positivity, go for interpersonal therapy. Why to waste your time if you don't know, how to do interpersonal therapy, refer it to somebody else. And then, Bob is here too, refer it to Bob, and then you will do the medication part, and then somebody else will do the behavioral component. Support this therapy with imipramine. This is a tricycline, 50% improved. Supportive therapy alone, 20% only respond. So I am sorry, Bob, and I am sorry, Humberto, but here is supportive therapy. Do it, but don't expect too much, okay? Throw in an antidepressant as well. Group therapy, and fluoxetine, 64%, okay? I don't like fluoxetine, I said before, but in this particular trial, in this particular research, they were testing out fluoxetine, and I have to respect that. But again, I will be very worried about using fluoxetine with HIV patients that are depressed. But group therapy, you can manage, the patient, and kind of psychologist, social worker, on the side, doing group therapy for them. And if it is group and placebo, it goes down to 48%. So it's no question that the medication, needs to be considered. But there is no question that the psychotherapeutic intervention do work, particularly interpersonal, and particularly if you are on the group therapy setting. So you have to consider it both. Psychotherapies, insight-oriented, interpersonal, as I mentioned before, cognitive behavioral, supportive, group, family, and couples, and combination. Sometimes you have combination. I will strongly consider that every patient that you have, sometimes people take a negative attitude. The patient have cognitive impairment. The patient has been with HIV now for about 15 years. Patient with HIV positivity, they're going to die. Sometimes I see, physicians, other professionals that take that type of attitude. Why should I waste time? It doesn't make any sense. Well, I want to die happy if I am going to die. So we have an obligation, to consider it, therapy, and consider it appropriate care for those patients, even though their life will be a little bit more limited than others. But this is, we went to medical school not to avoid dealing with this problem. We went to medical school to really confront this problem and do the best we can. So all of those particular therapies work in a way or another. You have to consider which one you will use and use it as necessary. Themes that you're going to see with these psychotherapeutic approaches. And I purposely, in my presentation today, I'm purposely trying to balance out the treatment. Because, again, people have a bias that, well, HIV, this is an immunological problem. Medication. No. Psychotherapy also plays a role. Now, why psychotherapy? Because those particular patients, as I underlined it early on in my presentation, they experience losses. Very common, once in a while, one of the group, one of the neighbor, one of the group that they socialize with, boom, one of them died. It has happened to me too. I had psychiatrists, friends of mine, that had died to HIV. And hell, I don't want them to die. I had experienced loss. They also are human beings. They also experience losses too. So loss is a very common factor that gives them a lot of stress. Anger. What a stupid I am. I never used, contraceptive. I never, took care of myself. I thought, that could not happen to me. Angry. How the hell I have been with this partner, for 3 years, and this partner didn't tell me that he was playing, games, with somebody else. Now he got infected, now he passed it on to me. How come he didn't tell me? He said that he loved me, but he didn't prevent it or warn me that he could give it to me. All that gives a lot of anger with those patients. Control issues. I feel that my mind is beginning to fault. my memory is not the same way that it's going to be. What should I do? Okay, I own a house. I have, retirement. Should I give up the house to somebody? Should I do now something before I die? Should I also take care of my family member? But if I had to take care of my family member, I had to tell them that I am about to die. I had to tell them that I'm HIV positive, and I had not told them. All these brings a lot of control issues that you, as a psychiatrist, as a physician, you and a psychiatrist, have to deal with. Death and dying, although they know that they are living longer, although they know that we have better treatment, sometimes they say, for how many years more I am going to live. So they are concerned about that. The impact on partners, some of them has brought in kids. They had adopted kids. Now it's no longer my die. What happens, when I die to this kid that I have been adopted or I am raising or something like that? That is a major problem. Fear of rejection. When I will be cachectic, when I will be about to die, forget it. My friends will abandon me. My friends will be ashamed of me, and then I will feel lonely. Dependency issues. Will I get demented? I already know that my cognitive functions are not working okay. What will happen when I get further demented? Will somebody volunteer to take care of me? Pain. They all worry about developing pain. Why? Because they see the pain in some other friends of them who suffer from the same illness. And they are frightened about suffering from pain. And also disclosure, the issue. They don't, sometimes they are ashamed, I am a physician and I got HIV. How the hell am I a lawyer, and the most important lawyer in Tampa, I got HIV. How will I tell my doctor? How will I tell my family? How will I tell my wife? How will I tell my kids? That is a major problem with respect to disclosure. For us, perhaps it's not a problem because we're not confronting that, but for 1 second, I think it's important the psychiatrist think, okay, instead of being a psychiatrist, let me put for 2 seconds myself on the other side of the room. Let me think now if I am a patient and how will I react to that. Major problems in this particular respect. Also, another thing that had to do with sexuality. Issues pertaining to sexuality. Why am I homosexual? Why did I become homosexual? And is it my partner, loyal to me? He knows that I'm going downhill, and he knows that I'm being so affected that my libido is also gone because of the depression. And what will happen? A spirituality issue, okay? Will God help me out? Will going to church and praying will also help me out in the afterlife or whatever. Guilt and regret, okay? I was stupid, I was stupid. I didn't prevent of getting the illness, and look at that, I am bright, I am a physician, I am a dentist, and I got sick, I got ill. Low self-esteem, a lot of self-criticism, as I already expressed some of them, and also the fact that although the United States has advanced a lot with respect to that, and in the book that Frank and I wrote, the issue of stigma and discrimination is very prominent to the address in that particular book, because still today, in the United States, the most powerful country in the whole world, the most educated country in the whole world, we still have stigma and discrimination in this country, not only against the person who suffers from HIV, but other persons as well. So we also have to take that into consideration and confront it head on. Suicide, here you have to be very reflective. It could be impulsive. Okay, boom, already saw it, enough is enough. I have been getting those treatments, and the side effects that I get, I am taking 10 different pills. The side effects, I have nausea, I have pain, enough is enough. I cannot take it any longer. But sometimes there is another one that are in good shape. And they says, well, I have lived a good life, and I do not have to face pain yet. I know that most probably my cognitive functions will be impaired. This is time, to stop. Okay, I enjoy what I did for X number of years, and perhaps I should. This is a difficult situation when somebody discusses with you this type of issue. You have to be neutral, but at the same time, you have to be very sharp, because what is in front of you, what they are telling you, is not, oh, you're a fool, come on, don't do it. You said that to a patient that is bright enough to talk about that, you lost the case. They are going to go see somebody else. And not in this country, perhaps Oregon, I think Oregon is is softening a little bit, but in Germany, for instance, in Holland, for instance, sometimes the physician says, well, you know what, you're right, okay? And let's do it properly, let's do it in the right environment, let's do it in such a way that it will be legal so that there will be no problems, about hereditary issues and this type of thing. And the physician help the patient to that. This is up to you. I am not saying do it or don't do it, but I want to make you conscious that it might happen more and more in the United States, and Oregon has already allowed this effect. Sometimes you have to admit, everything that I have said so far, you can manage it in an outpatient basis. Most of the cases are managed in outpatient cases, but sometimes, if the risk is very high for suicide, what the heck are you going to do? You have no other option but put the patient in the hospital. At times, you have a patient that is so cachectic, pain is playing so much of a big role. The patient had lost so much weight, the patient cannot handle it himself. It's too much. You have to admit him temporarily until he gains weight and the illness gets a little bit, the depression gets a little bit under control, but you sometimes have to hospitalize it. Need to start pharmacotherapy and medication where you need a little bit of a control environment. For instance, person is very depressed, and the person had told me about suicide occasionally. But I decided, for good or for bad, that for this particular patient, he had already several SSRIs, the right ones, he hasn't worked out. I'm going to put him in the hospital. I'm going to start the treatment in the hospital. Once the level where the depression is under control, then the suicide will go away. The suicidation at that time I discharged him. But I'm going to start the medication in a hospital setting right now, patient, because I don't want that he killed himself. I would feel terrible, so I put him in the hospital for a week or two. There are some medically ill persons, because we're not talking about depression, we're talking about a person that have a major immunological condition that impact over many, many organs in the body. The brain, the liver, the kidneys, and therefore sometimes it's so fragile about the multiple complications, medical complications that they have, that you put the patient in the hospital, and then you call for a medical consult to help you out. If there is history of bipolar illnesses with rapid cycling, I am not going to start antidepressant on that guy. I put him in the hospital, start the antidepressant. When the patient had not responded, with a rapid cycling, then I discharge him. But to have a person that have HIV positive, that has some cognitive problem, that have major depression, and on top of that, all of a sudden convert the person into a manic person, it could spread the disease even more out of the manic condition. No way. ECT. In some cases, you have to consider ECT. Even if the person is suffering from HIV positivity. It could be useful in that particular patient, the one that I mentioned just 3 minutes ago, that is very medically ill. The person cannot even feed themselves. They are so cachectic and so weak. You give 2 or 3 antidepressants, the patient gains a little bit of pep-up and energy, and then you stop it and then follow up, with other type of medication. Suicidal, the patient is so suicidal, you are against the wall, you have tried already several antidepressants, you could give ECT to that person. Psychotic patients sometimes, it's appropriate to also consider it, or persons that have resisted all time of medication. You have tried all of the ones that I mentioned, the stimulants, the novel antidepressant, all of them, and it hasn't worked out. It could be dealing, it could create a confusion, particularly if the patient has some cognitive functions already a little bit impaired. And if the person is beginning to develop central nervous system illnesses as a consequence of HIV positivity, then it's going to be a double impact on the brain, but sometimes you're against the wall and you need to consider it as well. Lithium carbonate, poorly tolerated. Patients that are taking all of those metabolic-oriented medication for HIV, they tend not to tolerate that well the lithium. It must be very closely monitored because you could develop neurotoxicity in 1 second. particularly a lot of GI effects. His patient is taking a lot of medication. The patient develops diarrhea with lithium, nausea with lithium, vomiting with lithium. Then you keep giving the lithium, then the patient, the HIV drugs are not working, then the disease goes worse, and then it's not a nightmare. On the other hand, however, you can check on the levels and use it, and you can also push fluid to be sure that the patient will maintain, the normal type of fluid that is required to maintain an appropriate level in the body. And you have to be also cognitive that sometimes patients with HIV develop kidney problems, nephropathies, and then you are giving it medication that is primarily excreted in the kidney, and if you don't think of that, then you're going to have a major toxic impact because not because of the HIV positivity, because the lithium that you are giving to that patient. But boric acid is effective. It will etch out lithium in patients with some organic problems or mania. It has less GI type of effects. May need to be monitored closely, particularly with respect to liver functions. The problem here is that you have to be very careful. If you're going to use boric acid, you must touch bases with the immunologist that is treating the person, because boric acid sometimes increases the level of cytobulin in the body. And then you may have a negative reaction because the patient has too much cytobulin in the body. So the best way of doing it is doing it concomitantly and in coordination with the internist or the immunologist treating that particular patient. And that it has been reports that when you use boric acid, there are replication, viral replication. So if you are giving boric acid and then all of a sudden the HIV virus began to replicate, we are told. So again, using boric acid without doing it in close coordination with an internist or an infectious specialist or an immunologist, a major mistake. Carbamazepine, elevated risk of pancytopenia in HIV patients, particularly those that are receiving macrotoxic therapies for the HIV positivity. CBC had to be done weekly, and we have to check also the level of cytobulin in the body because it increases. It induces its own metabolism, and this is a problem, particularly in the hepatic system, and it may decrease its own level as well as the level of other drugs. So I don't know, carbamazepine, I probably not use it at all. Clonazepam is very good. Clonazepam is very effective as a second or third agent to other destabilization. It's relatively safe, no problem, except you have to check the protease a little bit. It might decrease the effectiveness. So what you have to do really is to tell the immunologist, listen, I'm going to put this patient on clonazepam. Okay, check a little bit more careful. From the blood side point of view, the medication that you're given, and if something goes sour, you don't tell me immediately I stop the clonazepam. That's the way to go. And it's a very good regimen, particularly for those patients that have acute mania and you don't want to use too many other medications like lithium or the carbamazepine, and also for those particular patients that they don't sleep well. They are so stressed out and all that they don't do very well. Gabapentin, have been said that we could use it at 900 twice a day for a maximum of 1800 a day, is effective. And it's very good with patients who also suffer from neuropathy. As I mentioned before, many patients that have HIV positivity develop pain syndrome. And those particular patients, gabapentin, not bad at all. Lamotrigine and tomiparate, we're waiting for Frank. We don't know much about either one of the two medications. Those are two medications that have been used recently, and we have to get more research before we take a position in one way or the other. Neuroleptic caution is warranted, particularly with the traditional, the typical neuroleptics. HIV patients are extremely sensitive to side effects. For instance, sometimes Parkinsonism becomes irreversible in the patient population. Low potency neuroleptics have anticholinergic effects and may worsen the cognitive function that had already been compromised in the patient population. High potency neuroleptic increase the incidence of neuroleptic malignant syndrome, and in those particular patients, the potential of neuroleptic syndrome is very high. And atypical like olanzapine and risperidone all have been tried, and most of them have very good results. So go with the atypical and then go backwards. If that doesn't work, then try some others. Risk factor, if you are African American and you are Hispanic man, you are more at risk for depression, for suicide, for all kinds of issues in the patient population. If you are relatively young, 25 to 54, the risk factors are much higher. If there had been some suicide attempts or complete suicide in your family, suicide is a problem in the patient population. If your family have been impacted with any type of psychiatric condition, any type of psychiatric illness, the possibility of you, HIV patient, developing a psychiatric condition like depression is very high. There have to be any history of psychiatric disorder on yourself. And if there have been, as I said before, history of drug abuse, alcohol, abuse of dependence is a problem. And if you are a person that have very easily you get into distress and you have a very hopeless type of outlook for your life, then the risk factors are more problematic. Multiple losses, including loss of employment, which sometimes happens in this patient population, and also lack of insurance. They lose insurance, they will not become insurable anymore. The stress that produces is a lot. Lack of social support, as I said in the beginning of my lecture, and conflicts around sexual orientation, pain. When they have poorly controlled pain, that is a problem. The stages of HIV, as the HIV progresses and the illness becomes more complicated and complex, more easily they develop depression and suicide and all that. And when they begin to have cognitive function, they get worried. And then during that particular time, it could become more problematic. Complete suicide, it looked that there is an increase, no question about it, among the patients with HIV positivity than in comparison to the rest of the population. 3 to 6 increase fold in this patient population. As we have better and better antiretroviral medication, then the suicide rates are beginning to go down. This is very promising. And it's only elevated and comparable to other type of medical problems, like cardiac conditions and strokes and this type of things. In summary, mood disorders are the most frequent psychiatric complication associated with HIV disease. Mood disorders may be secondary to HIV complication or also to the treatment of those illnesses. And suicide risk could be elevated across the whole trajectory of HIV disease. And sorry that Frank is not here, but I do hope that you talk to him and told him, listen, Pedro, pay respect to you. Frank to me is number one in this area in the country. And if you are not sure about it, read the book, and then you will be convinced. Thank you for listening.